Okay, so as you can see here, these are different modes of getting insulin into our bodies. On the right screen here, we've got our insulin subcutaneous needles. And then on the left, we've got on this person's abdomen over here a insulin pump. This is called a tethered insulin pump. This is replaced anywhere from every 3 to 5 days, depending on the manufacturer. And so the patient just puts this in themselves. They learn how to do that. And this pump gives them a basal dose. The only type of insulin that can go in these pumps is fast-acting insulin, so Novolog or Humalog. And it gives them a very small amount of Humalog or Novolog continuously, like as a basal. And that keeps their blood sugar down a little bit. And then they give themselves a bolus for if they are going to eat a certain number of carbs, or if their blood sugar is high, they can give themselves a bolus for that as well. Over here is a continuous glucose monitor, and this is remote control. It can go towards the device itself, or it can go to someone's smartphone, and it's a continuous blood glucose reading, so that they can see the trends of their blood sugar and what is happening. So type 1, why would they go into hypoglycemia? Hypoglycemia could be just too much insulin injected. So for example, just as a personal note, when my son was diagnosed, he was 2, and so he was on diluted insulin. And when we switched him over to regular Humalog, I pulled up 10 units instead of 1 unit because of the switch over and gave him too much insulin. And then I had to just take him to the emergency room, and they just put a dextrose strip on him, and he was perfectly fine. But you can give yourself too much insulin. One typical reason why you can give yourself too much insulin is that your brain feels like it's going to eat a lot. You know how sometimes we're super, super hungry and you're going to just eat all this entire plate of food, and then you get halfway through it and you can't eat anymore. But you might have given yourself insulin for this entire plate of pasta, but only finished half of it. So now you have too much insulin in your body to take care of this pasta. So that's too little food for the insulin coverage. Again, hypoglycemia, when that happens, that liver converts that glycogen to glucose. You can, when you do become hypoglycemia, we're going to use fast-acting carbohydrates such as orange juice, your glucagon IM, and then your 25 grams of D50 IV push. So we went over these before. Just a reminder, in the hospital, we typically give this D50, and then if they can't eat anyway. But also if they're confused or disoriented at all, we're going to give them this D50 rather than giving them the orange juice. Glucagon, like I said, can be ordered, but they have an IV, and so it's better to just give them glucose straight into their veins rather than mess with the liver and try and get this glucagon to come out of convert the glucagon that's in the liver. So type 1 patho leads to DKA. So type 2 leads to a different form, and we'll get to that in a minute. So typically DKA nowadays usually only occurs in type 1s if they are not on a pump. So insulin pump users typically do not go into DKA. But basically, a diabetic ketoacidosis, there's, no insulin is being given. They have no energy. Again, remember, their body thinks that they're hypoglycemic because if no insulin, then there's no glucose going into the cells. And so what happens here is in order to get more glucose, they'll use up the stores in the liver. And in order to get more glucose, it actually starts to break down the adipose tissue for energy. And these are called free fatty acids. So free fatty acids can get broken down in order to get glucose into the bloodstream. And remember, DKA, the body wants more glucose in the bloodstream because there is no glucose going into the cells because there's no insulin. Now, free fatty acids called ketones. And I know you're thinking, oh, well, I was on a ketone diet. Ketone diets do not cause you to go into DKA. This is specific to diabetics, okay? So with type 1 diabetics, when those free fatty acids break down, they turn into ketones, which then turns into ketoacidosis. Remember, the glucose isn't going into the cells, so neither is the potassium. So the potassium is building up. And then our kidneys reabsorb glucose in the tubules as well. And so what happens is when we have this occur, that glucose leaks into the urine. Okay, and so then we get this osmotic diuresis due to that high concentration of glucose in the urine. Remember, think about how that high hypertonic solution, glucose is hypertonic, and then it's going to draw the fluids into the vascular system, and then they're going to urinate it out. And that's what happens as well, right, with the when we get that increase in glucose and potassium in the bloodstream. Remember, we just talked about how the body wants to dilute it because it shouldn't be like that. So it's drawing that fluid from the interstitial spaces into the vascular cell, causing that cell dehydration and electrolyte disturbances and a lot of diuresing. Okay. After this, then metabolic acidosis occurs. Okay, so we've got our cellular dehydration, we have increased potassium, we have ketones, and that all leads, that is basically DKA, diabetic ketoacidosis. Okay, this is life-threatening. Most type 1s are in DKA when they are first diagnosed, and their blood sugar is extremely high. Here it talks about blood sugar at being greater or equal than 250. However, most type 1 diabetics, when they're first diagnosed, typically it's usually over 1,000. So your home glucose kits do not read it at this point. It just says high. Okay, so in order to kind of diagnose this diabetic ketoacidosis, we've got blood sugar of greater than or equal to 250, a pH of less than 7.3, sodium bicarb less than 15 milliequivalents, and then ketones in the urine. Okay. Now, part of the problem for this is cerebral edema, and that is a severe complication. So this is extremely dangerous. When you get cerebral edema from DKA, there's 70% mortality rate, so that's huge. And part of that is due to the fluid shifts, due to that hyperosmolarity. And so they become dehydrated, everything is dehydrated, and you get this cerebral edema. And so we cannot overhydrate really, really quickly. We can't give them boluses. We have to go very, very slow because with that, too much of a shift would cause that edema to become worse. Okay, and we want to decrease that blood sugar very, very slowly. They use an insulin drip, and the only type of insulin that you can put in an IV is regular. Okay, so the insulin drip would be regular insulin. Okay, there's also something called an anion gap, and this is when a decision is made. Anion gap is used to make a decision on whether or not they're going to go on to an insulin drip. And if the anion gap is greater than 17 milliequivalents, then they will go onto an insulin drip. An anion gap is calculated as sodium, the sodium value, minus the chloride plus the bicarbonate. Okay, and the normal range is 3 to 15. So if they're above 17, it could be, doesn't have to be due to DKA, but it could be due to DKA, lactic acidosis, renal failure, and some poisonings. But this is the determination as to whether or not in a DKA patient, if we put them on a regular insulin drip. So DKA medications, it's the same as, that's funny, I have the same as DKA here, same as diabetes, but there's a few things. So we've got oral fluids if possible, normal saline, so isotonic to dilute, or 0.45 normal saline to hydrate those cells, right? So those cells are dehydrated. So chances are you're going to be on 0.45 first, and still very slow. This is where we want to go very slow, is the 0.45 to hydrate those cells. If we go too quickly, we can overhydrate them very quickly in this particular case, and then they could burst. And then once that is solved, then we'll move to the normal saline. The regular insulin, continuous slow drip. Once they reach 250 or less, then what we do is we slow it down. We slow that whole insulin drip down. We might add D5 half NS, which sounds funny because we're adding some dextrose in here, but it really is to stop that glucose from going down so slowly, due to the possibility of that cerebral edema. So it's kind of like a very, very tricky game to play, which is to try and bring this blood sugar down. We also want to then, once the blood sugar is less than 250, kind of convert over to subcutaneous. So we want to do that in a manner that we're not going to just completely stop this. We want it to overlap, so that we don't get too many highs or too many lows. The patient being in metabolic acidosis, we're going to give sodium bicarbonate to reverse that acidotic state. And then we're going to have to start to replace the potassium as far as the protocol is concerned. So there's going to be a huge potassium shift as well in regards to this, because with that regular insulin opening up the cell gate to take in that glucose, it's also going to be taking in potassium. So we're going to have very high potassium at the beginning, and then we really have to watch it very, very closely as to not overcorrect. And so there's going to be a point where we have diluted the vascular space. The insulin has taken out that glucose and the potassium and put it into the cell. And so there's going to be a point where you might have to actually start to do the replacement protocol because too much has gone into the cell. So very detailed. Metabolic syndrome is what we were talking about before, and this is what we call insulin resistance. So here's your metabolic patient, typically high blood pressure, low HDL cholesterol, high triglycerides, and it all comes to insulin resistance. In order to be considered metabolic syndrome, you have to have a cluster of 3 of these medical conditions, and intra-abdominal obesity, triglyceride, blood pressure, fasting glucose is increased, decreased HDL, systemic inflammation, or appetite suppressants. Like, so if their BMI is greater than 30, we can give them appetite suppressants. So a list of these here, 3 to 5 of them you are then considered to have metabolic syndrome. And that is basically the cause of type 2, one of the causes of type 2 diabetes and the cause of insulin resistance. So type 2 first is insulin resistance, just like we spoke about with that metabolic syndrome, and another is not enough insulin produced. So as we get older, we're not going to produce enough, as much insulin, and so then our cells are not getting into our glucose are not getting into our cells. The beta cells themselves start keep secreting insulin, but become exhausted, and that leads to the beta cell death. And so you can see the direct correlation here in type 2 with a younger person having metabolic syndrome and an older person who has just led a long life and everything is just starting to slow down. So one is overindulgence causing the beta cells to become exhausted, and the other is just an elderly factor. So with beta cell death comes less insulin production, and then of course glucose starts to build up in the vascular space. Now, where type 1 diabetics had DKA, type 2 diabetic complication is HHNS, which is hyperosmotic hyperglycemic state. And we'll talk about that shortly. Some of the type 2 medications, the PO. So with type 2, you can be on PO medications. You can also be on insulin. But some of the PO medications, and these are very, very common, are sulfonylureas, so glipizide, gliberides. And what they do is they stimulate that beta cell to release the insulin. The other is the DPP4 inhibitors. So you've probably heard of Januvia, and that increases insulin secretion and decreases the glucagon secretion. So it decreases the stimulation of those alpha cells, but increases the stimulation of those beta cells. And then metformin is very, very common. And what this does is it works in the liver. So it reduces the production of glucose in the liver. So as you can see, they all kind of work in different ways. Sulfonylureas stimulate those beta cells. DPP4s also stimulate the beta cells, but decrease those alpha cells. And then the biguanides, which is metformin, reduces the production of glucose in the liver. So we can kind of hit it from different sections. So interestingly enough, these hyperosmolar, the HHNS, is very severe to the point that there's actually more deaths with HHNS than there is with DKA, believe it or not. Everything is severe with HHNS. The hyperglycemia is very severe, hyperosmolarity, and the dehydration is far more prevalent than in DKA. Part of the reason for this, they think, is that when someone is in DKA, it happens very quickly and they are aware of it very quickly. But with HHNS, this can start to creep very slowly. It can creep up very slowly. And so they could be in this HHNS for a much longer period than a DKA patient would be before they were noticing signs and symptoms of this. A type 2 diabetic typically that is especially uncontrolled, they might be on the higher range of their blood sugar. And for some reason, it seems to be a little bit harder to control. I think a lot of that is got to do with lifestyle change and how difficult that is, especially as an adult. So there's more hyperosmolarity going in, so that fluid shift because of that very increased blood glucose. And so again, that body wants to dilute the blood. We get the whole intracellular to extracellular vascular shift, dehydration and thirsty, right? Remember, so they're thirsty because they're dehydrated, they have cellular dehydration. So you know how the diabetic patient, when they have high blood pressure, it's the P's, right? They polyuria, polydipsia. And so, did I say polyuria? Polydipsia. And so that's because their cells are dehydrated, and so they're really thirsty. And then we have this vascular shift of fluid. And so now you're going to get more urine output because there's extra fluid in this extracellular fluid. Body, again, thinks it's hypoglycemic because there's no energy in the cells. And then again, a vicious circle of that glucagon being released to increase the blood sugar because the cells are not getting any energy. So it's just this vicious circle when the insulin is not working properly. So with type 2 diabetes, DKA does not happen because they have endogenous insulin. So the endogenous insulin, which is, they do have insulin in their body that is working, they just have very little of it. But that small amount actually blocks that fat breakdown, and then they don't get the ketones, and then they don't get the DKA. So it's similar to, remember how I was talking about patients that have the insulin pumps? They don't have endogenous insulin, but they have that background basal insulin that also helps prevent them in most cases from going into DKA. So it's the patient that does not have basal insulin on board that go into DKA. They still have the polyuria, like we were just mentioning, because of the dehydration. They have mild metabolic acidosis, but there's no ketones in it. Okay. Their blood sugar is to get this diagnosis is greater than 600. But remember how I told you that with a new diagnosis for a type 1 patient, it's usually over 1,000. The DKA slide that I just went over that said greater than or equal to 250, that's not the new patient. That's the ongoing type 1 diabetic patient that if they're, a pH and bicarb and everything, all kind of come together, that causes DKA. So in this particular case, this blood sugar of greater than or equal to 600 is their blood sugars are going to be normally high for a long period of time. And so that is the problem with all of this fluid shift. Approximately 25% of these patients present in a coma and have major fluid shifts. The electrolytes are falsely concentrated sometimes because of that dehydration. And so once we don't necessarily want to correct the electrolytes yet. This is going to depend on the physician and the patient's presentation. So you're going to be doing a whole bunch of different things with these electrolytes depending on how they present and what they are like. So there you might be replacing some, you might not be replacing some, depending on if they're concentrated or not. But that is going to vary dramatically over the amount of time for this patient who is in HHNS. Okay. The treatment is the same as DKA, except there's no sodium bicarb because they are not in ketoacidosis. Okay, so we want to hydrate the cells with that 0.45 and then use isotonic to help dilute as well. Okay. The key thing here is that we need to put in the fluid before we put in the insulin. This helps prevent hypotension when the fluids start to shift. So if we put in insulin right away and the cells open up and fluid shifts in, we could become hypotensive and we could go into hypovolemic shock. So we want to get these cells hydrated first, okay? Once we begin this, then we can go to that IV insulin again, which is the regular insulin. This is basically the same format as we do with that DKA. Sub-Q and then potassium replacement protocol, depending on the fluid shifts and how it is diluted. So labs, hemoglobin A1C, hemoglobin A1C. I'm sure you learned with your med-surg class that this level is presented over a 90-day period. This is the best way to determine if there's a possibility that your patient is non-compliant. A 1 blood sugar reading does not indicate that they are non-compliant because you're looking at one single amount of blood glucose readings. And in fact, a lot of your patients in the hospital that have type 2 or type 1, their blood sugars are going to be elevated because when a patient is sick, they naturally, and have some inflammation, they naturally release cortisol. Cortisol is a natural steroid to decrease inflammation. Steroids innately, whether it be through cortisol levels in your body or through supplemental steroids, increase blood sugar dramatically. Case in point, my son was on steroids for strep throat because his throat really swelled up. And I was giving him 3 to 4 times the amount of insulin that I normally give him, just to try very hard to keep him in the higher range of normal. So it's a drastic increase. So, your patient's blood sugar is 180 or 240, and you can't seem to get them down. Don't think that they are non-compliant. Most of that is the fact that they have cortisol in their body that's being released, and they need a much, much higher dose of insulin than they normally do get. On average, higher hemoglobin A1Cs also have the risk of developing complications down the road. You want to check their labs for ketones and protein. And then there is a C-peptide test that you can do, and that actually determines the amount of natural insulin secretions from the pancreas. So a type 1 patient, at the beginning of their diagnosis, they might still have a mild amount of insulin secretion, and a C-peptide will help determine um, when for sure they are completely on their own as far as insulin production. They don't usually do this for type 2 diabetics until maybe the PO medications, the anti-diabetics are not don't seem to be working as well. And so then they might take this test to determine if they need to maybe go over into insulin rather than just do the PO tablets. So medications that affect blood glucose, we've already gone over these a few times. Right here, sick days. So sick days, cortisol releases due to the illness. And so you might need an increased dose of insulin and frequent blood checks. Okay. Also, sick days that you're vomiting. So if you're vomiting, you can't eat. So we're going to need to maybe decrease that insulin dosage and frequent blood sugar checks. What increases blood glucose are diuretics. So if you become dehydrated, you can, from diuretics, your blood sugar can become more concentrated. Steroids, like we talked about just now, and then fentanyl or Dilantin. So all of these can increase blood glucose. Corticosteroids being the worst. What can decrease blood glucose? Well, so beta blockers can't decrease blood glucose, but what they do is they block the signs and symptoms of hypoglycemia. It's a blocker. And so think about that sympathetic nervous system. And so the signs and symptoms of hypoglycemia, right, are sweating, tachy, diaphoretic. And so the beta blockers can block those signs and symptoms. So that's a bad thing when you're hypoglycemic. And if you are not getting those normal signs and symptoms that you're hypoglycemic, because then you can't take care of that hypoglycemia. Alcohol is interesting. Alcohol, typically, we tell patients that it decreases blood sugar, but it really does depend on the patient and the type of alcohol that they drink. ACE inhibitors, although given frequently, can also decrease the insulin requirements. And things like ginseng, juniper, berries, and garlic can also decrease those requirements. So we just have like a nice little overview here of DKA. What we just kind of went over with DKA, just in a nice little summary. See here how it develops over hours, like hours to 1 to 2 days, yet HHS will develop over days to weeks. So it's a much longer period. Okay. And thank you for listening.